undergraduate studies at the University of Oregon and also performed research in physiology and physical chemistry. He continued his research interest while investigating liver functions at the University of California, San Francisco. Dr. Saley co-authored several scientific and medical papers. Medical School Experience the Journey describes the author's time while attending medical school at the University of California, Irvine. He subsequently completed internship and residency training at Ventura County Medical Center, UCLA. After completing his medical training, Dr. Saley practiced family medicine, emergency medicine, and urgent care in Oregon, Utah, and Minnesota. He also taught medical students at the Oregon Health and Sciences University and the University of Utah. He's a fellow of the American Academy of Family Physicians, a lifetime award for distinguished service. He has also traveled extensively in North America, Europe, Asia, and Oceanasia. In Medical School Experience the Journey, the author describes 4 months of his senior year in medical school while traveling the Pacific Rim and studying at the Bangkok School of Tropical Medicine. So thank you so much for joining us today, and I'll let you take the floor.
Well, thank you very much for having me. I'm very excited to be here. My book, as you said, just describes my time at the University of California at Irvine. And it actually was just written initially for my children, but after thinking about it a while, I found that there probably were people out there like myself who was interested in medical school, but really had no idea what really went on in medical school. And so I wrote the book, and here it is. And so the book opens out by discussing my first day of medical school. And I went to, again, UC Irvine, and I lived in nearby Newport Beach, and it was a very short drive. And I arrived at the campus, and there was 92 of us who were all starting that day, and we were all just extremely excited because Southern California is a melting pot. We had people who are descendants from really all over the world who are in our class, and including many people who are the first generation to attend college or let alone go to medical school. So it was a very big deal and a very, very exciting day. In our morning session, they set up a series of tables in the cafeteria with attendants at each to assign us our student identifications. Particularly important when you're on the wards to let others know that you're just a medical student and kind of at the bottom of the hierarchy. We got our parking permits because we worked at several different hospitals, UCI Medical Center, the Long Beach VA Medical Center, Long Beach Memorial Hospital, and numerous Metropolitan State Psychiatric Hospital, and numerous private clinics. And we were given a free stethoscope that morning, and we got our class schedules, and several organizations were seeking our participation. The American Cancer Society was there, and they had a student organization called the St. George Society, which I was particularly interested in joining. I went to medical school because my mother died of breast cancer when I was 12 years old, and medical illness had a huge influence on my life. And so I joined them. And after that series of tables in the cafeteria, we were given time to meet each other and socialize. And it was really quite very interesting. And then we had a short lunch break. And then we moved to our classroom. There are 2 main classrooms for teaching in the first 2 years. Each were built into the side of a hill with an indoor amphitheater like classrooms. And one was for the first year students and one was for the second year students. And we had a series of speakers come in. The first was the esteemed chancellor of the University of California at Irvine. And he was a very distinguished appearing man. And he came in and sorry, here we go. And discussed how we were all lucky to be at this great university, um, and that we needed to behave appropriately and act civil and to present good appearance for the community, and we were really in the spotlight now. And then the second speaker was the dean of the medical school, and he was a somewhat more disheveled, overweight, gray-haired smoker who not in the class, but was kind of a chain smoker, and just quite a contrast. But he also basically gave us the same messages that we needed to, behave well. And then the next speaker was actually a psychologist who told us a couple alarming facts. She stated that everyone there was obsessive compulsive, or we wouldn't be in medical school, and there was no way to be admitted without being somewhat. And of course, we didn't like being called names, but it in fact was true. And she also told us to anticipate depression and emotional difficulties, and of the importance of finding outside interests to continue during medical school so that we could keep our life in somewhat balance. And then the registrars showed up and told us how much this was all going to cost us, and that if we weren't sure we wanted to go to medical school, we should really change our mind before we paid tuition that day, because it was just going to get worse and worse and worse. And frankly, it was quite unsettling, but it was the way it was. And then our last speaker of the afternoon was the most interesting. It was a trauma surgeon who showed us a series of slides on trying to desensitize us to blood and guts, essentially. And he showed one traumatic slide after another, after another, after another. And finally, there was a slide of an elderly woman with a very large butcher knife sticking out of her chest. And one of the students fainted into the aisle, and they briefly turned the lights on and attended him and escorted him out. And then the lights went off and the slideshow continued. I don't think anybody starts medical school desensitized to trauma, and it's just an experience of seeing things over and over and over again. And that was our first day. And afterwards, I was an older student because I'd taken some time off to do research before medical school, and some of the older students got together and we went out to a Mexican restaurant for dinner that night. And then the next day, our classes began. We had embryology was our first class. And for those of you who don't know, embryology studies life from fertilization to 8 weeks. At 8 weeks, the embryo turns into a fetus. And this class lasted a total of 9 days. And then we had a final exam, which counted 100% of our grade. And needless to say, that put the pressure on us, because if you were to fail this class, then you have to repeat it before you could move on. And it's only offered once a year. So it basically meant taking an extra year if you failed a class to get through things. So fortunately, it wasn't a terribly difficult class, but just the same, the pressure was on. And we had 2 textbooks. Anyway, embryology was fascinating. We studied how the embryo grows and twists and turns, and the 3 basic cell lines, the endoderm, the mesoderm, and the ectoderm, with the ectoderm forming the skin and the nervous system, and the mesoderm forming the muscles and the bones and the connective tissue, and the endoderm forming linings to the internal organs and the pancreas and the liver. And anyway, it was a fascinating class. I loved it. It was terribly informative, and but it was over in 2 weeks. Our next class was human gross anatomy, and that was probably my favorite class of the first 2 years of medical school. We had 2 cadaver labs with 10 cadavers in each lab that were connected, and the students were broken down into 4 dissecting groups when we would take our turns dissecting and presenting to the other students, and then we would watch the other groups do the same to us. Our group was given the color of green, so we were all enthusiastic at the time, and we called ourselves Gangrene, and we bought matching T-shirts, and anyway, it was quite exciting. We were also given bone boxes that contained a complete skeleton for us to take home and to use. And the labs were open 24 hours. We had our own key, but we had access 24 hours a day. Mnemonics were very important, and figuring out base words were very important. Like, you know, hypo means below and hyper means above, and ipsilateral means the same side, and contralateral means the other side. And so there was a lot of terminology development in anatomy. And the dissections were broken down into main regions. There was the head and neck region, the thorax, the abdomen and pelvis, and the extremities. And anyway, I just loved anatomy. Every cadaver had different unique findings. A lot of the findings are the same, but each one had unique findings, and they were a favorite source of questions for our professor to ask. And we also had a great assistant professor who held review sessions. In fact, we liked the assistant professor so much that we had a basketball tournament near the end of the class dedicated in his honor, and we all got together and celebrated the end of anatomy. So that was all great fun. The third class that we had that semester was histology, which is also called microscopic anatomy. And histology basically looks at stains as like if you were to take a biopsy sample from surgery and then prepare it and stain it and look under the microscope, that's what it was. It was literally hundreds and hundreds and hundreds of slides stained with H&E stain generally, and they were purple and pink and purple and pink. And not my favorite class. I personally found that I really almost never use that information in my clinical practice, and should have probably been more reserved for pathologists, but there probably were questions on it on the part 1 of the board exam, so we went through it. And then the last class that first semester was biochemistry. And my guess is everybody who's listening probably knows what biochemistry is. But basically it's the chemical reactions of life, and talks about energy production and how oxygen is utilized to make energy, and how metabolism works, and DNA and RNA and those type of things. But I think probably most people know what biochemistry is by now. So I think that's all I'm going to say on that. In addition, there was actually a surprising amount of free time and time for volunteering. I entered assuming I was going to be totally overwhelmed, and I wasn't. It actually, to me, medical was much more pleasurable and less difficult than my undergraduate studies were. I had to work my way through college, and it was just very difficult, whereas medical school, I didn't work except here in medical school, and I thought medical school was a blast. I really loved it and would recommend it to anyone. And I'm sure you all would be happy to take that invitation. So then that was the end of the first semester. So then spring semester first year, we had human physiology and a series of microbiology classes. And human physiology really is the chemical and physical functions of the human body. And to me, it seemed like it really integrated biochemistry and anatomy. You know, biochemistry is so microscopic and anatomy is so gross, and physiology kind of tied the ends together. And I really, really, really liked physiology and learned a lot. There were numerous areas that we learned about. We learned about the nerves and individual nerve conductions, and how nerves transmit and speak to each other through neurotransmitters, and how those neurotransmitters are degraded to turn off those signals, either by being reabsorbed or by being broken down. We learned about different types of muscles. There's 3 different types of muscles in the human body. There are striated muscles, which are the muscles that we all think about, are the biceps and triceps are striated muscles, but there's also smooth muscles, which line our airways and our blood vessels. And those are generally controlled by the autonomic nervous system, which consists of the sympathetic and parasympathetic nervous system. And those are functions that are regulated without our conscious control. We learned about the kidney and individual nephrons and the loop of Henle, and how the kidneys help adjust pH regulation, as well as the lungs. A body's pH is normally at 7.40. And if you become acidotic, that pH decreases, like if you're sick or overexert yourself and develop lactic acidosis. And the body, the enzymes within the body tend not to work if the body gets very far outside of that pH range. And so we have compensatory mechanisms to maintain that pH. And the acute way is by regulating our breathing rate. Carbon dioxide, as many of you would recall, is in equilibrium with sodium bicarbonate, or with bicarbonate, and it's essentially an acid. And so if you breathe faster and you blow off more carbon dioxide, that causes alkalosis and raises pH. And if you breathe slower, then you retain more CO2 and that lowers pH. So that's the acute way to, it's called respiratory compensation. The other way to compensate is through metabolic compensation, and that's done by the kidneys, but that's done at a much slower rate. And the kidneys can excrete more hydrogen ions or reabsorb more bicarbonate to adjust the pH. And many more very interesting things. My favorite professor was one of the teachers. He ended up winning the Golden Apple Award as the best medical science teacher in the United States a few years later. And he then became dean of the medical school for medical sciences. And I actually just met up with him just a few weeks ago after not seeing him for 35 years. And it was great, a lifelong friend. Our next class, that second semester, spring of the first year, was microbiology. And the microbiology was divided into several different components. There was the bacteriology section, obviously where we studied bacteria, in particular ones that cause disease in humans, such as E. coli, staph and strep, and those. And we also, we learned characteristics about each organism and their sensitivities to antibiotics. And we also had a laboratory portion where we actually grew out these organisms on growth plates. And then we would put various antibiotics in different locations on the growth plate to check for sensitivities to the antibiotics. The next section was virology. And when I went to medical school, AIDS was, HIV and AIDS was a relatively new illness. And when I started medical school, there was no treatment for it whatsoever. And everyone who got this dreaded virus died. The first drug was developed 3 years later in 1987. So we studied HIV a lot, and other viruses as well. Obviously, numerous viruses that cause human disease, such as the hepatitis viruses and human papillomavirus and herpes virus, and on and on and on. Obviously, viruses do not respond to traditional antibiotics, and there are far fewer antiviral medications still today, but at the time there was even far fewer. The next section of our microbiology class was parasitology. And I actually found parasitology very interesting. I had traveled a lot in regions of the world where parasitic infections were very common. And having had them myself, I took a personal interest to it. And parasites really cause a lot of morbidity and mortality still in a lot of the world, although the Gates Foundation has made significant inroads, particularly into the malaria problem. And then the last component of that class was immunology. And this is studying the immune system and both how we make antibodies and have cellular immunity against infections. And as terrible as the HIV epidemic was, one good thing was that it really helped us do a lot of research in immunology. And a lot of these medicines that we have today are immune system modulators that I feel got a big boost by the research that was done because of the HIV epidemic. And by that time, it was into July, and we were given a 6-week vacation, and some of our students rested and recovered, and some worked to make some money. I actually set up an elective rotation at the University of Hawaii at the John Burns School of Medicine and doing research on developing a malaria vaccine. There was an old tuberculosis hospital, Leahi Hospital, that was closed, and then they made it into a tropical and infectious disease research center. And having had quite a lot of biochemistry research experience, I went into their lab and worked for that period and worked on developing a malaria vaccine. We, unfortunately, while I was there, we did not have success, but just in this last year or two, I see where they've now released the malaria vaccine in Africa. It seems to only be about 40% effective, but 40% is a lot more than 0%. And so that was all a good thing. And that was the end of my first year. And then in the second year, it was really great to see the incoming students arriving, because it seemed like just yesterday that we were the ones, we switched to the other classroom and they moved into our classroom, and there was all these enthusiastic and fresh faces, and my crowd wasn't quite as enthusiastic coming back for the second year, but at the same time, there was a growing sense of self-confidence that, we had made it through the year, and that it seemed that medical school was not the impossible journey that we had feared it was. We also, as a class, we were subjects to a cardiologist's study. He was studying the effects of oat versus wheat bran on our cholesterol. So we all had our cholesterols drawn, and then we were each given literally garbage bags full of muffins. We were to eat 2 muffins a day for 6 weeks and then have our blood redrawn. And I felt there was probably an inherent bias in the study, so I made sure and ate a lot of cholesterol containing things so I wouldn't, bias the study. And my cholesterol really wasn't affected very much, but I must say the classroom did take on a new odor from all those muffins. So we were all happy when the study was over. So anyway, our actual first class of that semester was human pathology, which of course is the study of human diseases. And this was a tough class. It made all of the classes in my first year seem relatively easy. In addition, we had a exceedingly rigid professor who seemed to find very little excuse for us not knowing the questions that he was asking us. And there, we all know about the major pathology like heart disease and the various types of cancers and lung disease and COPD and diabetes and strokes and pneumonia and stuff. But in addition to those, there literally are thousands of other diseases. A lot of them are genetic diseases and mainly affect the pediatrician, but the volume of things that we had to learn was staggering and humbling. And, of course, at a University of California Medical School, there was generally most people had done pretty well in school. And in pathology, our professor, out of 92 students, he failed dozens of us. And we were told when we started that the University of California paid about $100,000 above our tuition for each student for every year. And the administration at the medical school did not see that it was the right thing to make the University of California pay millions of extra dollars, plus all of these students have to spend an extra year in medical school. And so there was an intervention, and most or all of the Fs were raised to Ds, but none of the other grades were raised. And I received a B-, which was my lowest grade in medical school, but I didn't get a C or an F, so there we go. And then neuroanatomy was the next class that fall. I'm sorry, yes, and we studied the central nervous system, which is the brain and the spinal cord, and the peripheral nervous system, which occurs after the synapses from the central nervous system. And we also studied the autonomic nervous systems, parasympathetic and sympathetic nervous system. We studied the hypothalamic pituitary axis. I believe there's 8 hormones released from the pituitary, which then go to regulate other places in the body. And of course, we learned the areas of the brain that control various functions, and the tracts that carry the nerves. And vision actually was a really interesting thing to learn about, how the 2 eyes collect different visual fields and then cross over at the optic chiasm of the optic nerve, and how it's integrated in the brain. And just really a very good, interesting class. And that was it for the fall semester. And then in the spring semester, we had pharmacology, clinical pathology, and examination of the patient. And in pharmacology was another very difficult class. It was just a huge volume of memorization. The intellectual part of it, other than memorizing, wasn't too difficult, but the amount of medicines, there was 10,000 prescription medicines at the time. And there was over-the-counter medicines and supplements and vitamins. And we had to learn the brand name and the generic name and the dosages and their mechanism of action and their side effects and the drug-drug interactions. And, it really was a volume overload. I had mentioned that my friend had become the dean of the medical sciences. And when I talked to him recently, he said pharmacology was one of the classes that they made major changes in, just because the volume of information was overwhelming. And our professor seemed to like to teach us historical perspectives on drugs, which were no longer in use, and it seemed a bit much. But anyway, that was the end of our last purely classroom course. The next class was clinical pharmacology. And we spent a lot of time going to the hospital morgues and looking at deceased people and being quizzed on what we thought was their demise and what they could have done about it. But the major portion of this class was actually learning laboratory medicine. Pathologists oversee every medical laboratory in the country. It used to be that you could take extra classes and be a non-pathologist and do that. In fact, I did that, and I was a medical laboratory director at 2 different high complexity laboratories, but they've subsequently changed the laws that unless you're grandfathered in, it had to be done by a pathologist. But we studied blood cells, the types of cells, red cells, white cells, platelets, abnormalities of those cells, blood types, transfusions, chemistry, serum chemistry, and the significance of the sodium and potassium and bicarb, et cetera. And then the other thing that we did is we had they called a dog lab. And it was a 2-day session where live animals, live dogs were placed under anesthesia, and we performed procedures on them. We learned how to suture and about various ligatures and tying knots and inserting IVs and venous cut downs. And the second day we did more invasive procedures like chest tubes and central lines and surgical procedures like removing the gallbladder, et cetera. Emotionally, it was a very difficult thing for most of us, and some people really had a very difficult time emotionally and tried to get out of it, but we were required to do this. I think today that some of this is done on simulators, and but at the time, that's the way it was. And I guess so what I learned about medical school is you just kind of do what you have to do, even if you don't like it, to get through. And last class that spring semester before we started our pure clinical rotations was examination of the patient. And this was done at UCI Medical Center. And I got to do this with my really good friend. Our mentor was a cardiologist from Korea who was doing a fellowship at UCI. And he did a great job of teaching us. We learned about what's called the SOAP format. And SOAP is subjective, objective, assessment, and plan, where the subjective is what a patient can tell you. Their history of present illness is why they came to you. Their chief complaint is why they came to you. The history of present illness discusses those symptoms. Then they also discuss their past medical history, their past surgical history, their medication lists, their allergies, and then what's called a review of systems, where you go through every organ system and ask them tons of questions about problems they may have been having. Then the objective are things that you can see or measure, like the vital signs, and then your physical exam. The physical exam, actually, if you do a good one, is very detailed. In the book, I probably spent 4 or 5 pages just discussing the things to look out for on your physical exam. Way too much to really go over tonight. The assessment is what your opinion is of what that patient's problem it is. And it may be the actual diagnosis, or it may just be something like fatigue of uncertain etiology. And that's where a differential diagnosis comes in. In fact, learning how to do a differential diagnosis is one of the most important things that you really can learn in medical school. And that's knowing enough about disease to know the diseases that can cause the symptoms that your patient can have. And then the P is for plan, where you set out your plan, what tests you want to do, what scans you may want to do, what consultants you may want to have, and what their projected time course is. And then the last couple of things we did before we started the rotations, we did a female pelvic exam, which was organized by the gynecologists, where they hired models to come in and walk us through a pelvic exam. And then we also did venipunctures. I learned how to venipuncture. And this one we did on each other. And having somebody draw your blood when it was their first time was quite an interesting experience. We actually had one student faint as they were doing it, and it bent the needle in the subject's arm and creates quite a stir, and everybody got all upset. And anyway, it seemed to go better after that. But that's part of medical school. It's just learning. And then finally, what we're all looking forward to is the third year. And when we go into the clinics, and our third year was broken into 5 different 10-week rotations: pediatric surgery, obstetrics and gynecology, internal medicine, and the psychiatry rotation. And so in pediatrics, my first assignment was a 2-week stint at the newborn nursery at UCI Medical Center. And at the newborn nursery, these are all babies who have been already examined at the time of birth by one of the resident pediatricians, and they're felt to be healthy and didn't need to go to any of the more intensive nurseries, and were just sent to the general nursery, and it was a good place for medical students to be. We had a supervisor who was a PA, and he was very regimented and very committed to teaching. And we literally got to examine dozens and dozens and dozens of newborn babies. We checked their hips. Dislocation of the hips is a common birth defect. And of course, check their eyes for the red reflexes, make sure there wasn't cataracts, and their mouths for tongue tie, and their lungs and hearts for murmurs, and abdomens for masses. And it really was just a fabulous experience. And by the time of, I think we did pick up a couple things. I think we picked up a missed fractured clavicle, which occurs more commonly than you would anticipate. And I think an inguinal hernia that wasn't detected. But for the most part, it was taken care of. Healthy kids. Of course, jaundice is a very common problem in the newborns. Jaundice is caused by an accumulation of bilirubin in the blood. When the fetus is inside the mother, they have a special type of hemoglobin called fetal hemoglobin that is more attracted to oxygen than the mother's hemoglobin is, so that it would come off the mother's hemoglobin and onto the fetal hemoglobin. And once the baby is born and then breathing air, then you don't need this fetal hemoglobin, and it's rather rapidly broken down. And if the liver cannot conjugate it as fast as it's broken down, then it accumulates. And if it accumulates at too high of a level, then it can cause severe problems and even death. And years ago, an astute nurse noticed that babies in front of the windows seem to get better faster, and so that light breaks down. So typically they're placed under fluorescent lights these days. My next pediatrics assignment was in outpatient pediatrics, and this was done at Long Beach Memorial Medical Center. And that was a 4-week rotation with myself and another medical student and a couple residents and one attending. And basically, we didn't do any inpatients, and it was just all outpatients. And most of it was just routine well child care. And in our area, we have a lot of immigrants, and many of them had not been fully vaccinated. And so we learned how to catch up on vaccines. And we often would send social workers out to homes that we were somewhat concerned about the baby getting enough to eat, and just doing everything we could to make sure that these kids did well. And of course, we saw lots and lots of middle ear infections and sore throats and asthma and things like that that are common to young children. My next rotation was inpatient at inpatient pediatrics at UCI Medical Center, and that was a 4-week rotation. And we did no outpatient, it was all inpatient. And every person who did not have an assigned physician every patient who did not have a private physician went to our service. And so we would admit new patients and discharge old ones. We had a lot of cancer kids that we cared for that I found particularly distressing. As I said, my mom died of cancer when I was young, and I went to medical school thinking I was going to be an oncologist. But after pediatrics, I knew that I couldn't deal with really, really sick kids. I love kids, but I couldn't deal with really sick ones. But We had a lot of other problems, cystic fibrosis and congenital defects, spina bifida, and things like that. Very interesting rotation. Being an enthusiastic medical student, I took it upon myself to take the kids who were able to leave the wards down to the plaza outside the hospital so they could get some sunshine and kind of do some non-doctor stuff. And some of these kids spend so much time in the hospital that it just got to be too much. And as a result of that, I got a really great recommendation, and I used it for residency. Our next rotation was surgery, and the first day of surgery, an experienced nurse told us the rules of the OR and what we could touch and what we couldn't, and how we had to behave, and taught us how to scrub our hands at length. And she did not have any time for the goofiness of medical students. She was a very dedicated, serious nurse. My first actual rotation was in plastic surgery, and I followed a private practice plastic surgeon. And then we went to these hospitals as well as to numerous other private facilities. And I tell you, I took on a new respect for plastic surgeons. I used to think, oh, it's just cosmetic stuff. And I learned a couple of things. Number one, it's not just cosmetic. They do reconstructive surgery as well. And number two, what may seem trivial to one person, if you're the person that has that problem, it's not trivial. And, what I previously would have thought was cosmetic stuff turned out to be life-changing events to these people. So it was great. I made a blunder on my first surgical case. I was so excited and got all scrubbed in, and I needed to adjust the light, and instead of adjusting the sterile handle in the middle, I touched the edge, which was non-sterile, and the anesthesiologist kicked me out of there and told me to go rescrub and regown. And of course, I was thoroughly embarrassed. But, and at the time I was upset, and in retrospect, it was like the best thing and the absolute right thing. Patients need to come before our egos, no doubt about it. So anyway, good learning your experience. My next rotation was urology, which I did at the VA. And there was a lot of urology residents, so I wasn't able to do any surgery on that rotation, but we did a lot of cystoscopies. At the time, there weren't flexible cystoscopes, and so we had to use stainless steel tubes, mostly in men, of course, and it was kind of a horrifying experience. The next rotation was ear, nose, and throat. And of course, they take care of the common ear problems and nasal problems, such as polyps and deviated septums and enlarged tonsils. But at the VA, there was also a lot of cancer of the head and neck. And ENT doctors have this one procedure called a radical neck dissection that takes 10 to 12 hours, and that they're scrubbed in, and that's a long time to be in one place. And they're all excited to get to do that. My next rotation was orthopedic surgery, and that was done at UCI Medical Center, and that was 2 weeks. And of course, that involves repairing bones and joints, and generally trauma or hip and knee replacement from a series of traumas. That was at UCI, and there was a lot of residents. So I got to scrub in, but was generally the second assistant, and got to watch and learn, but not really do a whole lot. Most of the residents I played against in intramural basketball, so I kind of knew them. It was comfortable. And the last 4 weeks was general surgery, which I did at the VA. And I had an excellent mentor. He was meticulous in his surgery, and he was trained in the old school, and he taught the old school. And the first week or two, I got yelled at several times a day for not standing up straight or not paying close enough attention or whatever. But as the time went on, I actually developed I felt quite good surgical skills, and he really taught me a lot. And I really enjoyed that. So our next rotation of the third year was OBGYN. And this one, I really liked what they did because they spent the first week teaching us the things that we needed to know to practice OBGYN. And as opposed to some of the other rotations, they just threw us in. So, we learned about prenatal care and labor and delivery and sexually transmitted diseases and birth control pills and just a lot of things that we went into blind. But after that week, we really had a much better idea. And the first few weeks then I was in the women's clinic and we were doing, a lot of birth control pills and dysmenorrhea and vaginal infections. At the time, women had to have a prescription even to treat yeast infections. So we saw a lot of vaginitis, various types. A very good clinic, very busy. We had a rather difficult resident mentor who was extremely intense and told the medical students we got 5 minutes per patient, and any longer than that, he'd get on our case. And the very first day, I went and saw a patient. I came out and he wasn't available, and I waited and I waited, and I thought, well, my 5 minutes is up. So I chose to go in and see another patient. And by the time I came out of that second room, he started screaming at me when I walked out the door. And I guess he didn't understand that I'd seen my second patient, but very, very intense individual. So it was a good learning experience, but kind of scary. My next rotation was inpatient gynecology and oncology. Our director of OBGYN was a famous gynecological surgeon, and we got a lot of referrals. So we did a lot of ovarian cancer, and it was a difficult rotation. We saw some pyelonephritis in women and some other things, but really a lot of oncology. And I was allowed to assist on surgery some, but it was emotionally trying rotation. And then my last rotation was labor and delivery, which was great. And I think what most people think of when they think of OBGYN. And once again, we only could see patients who didn't already have either a resident or a private doctor. So I didn't get to do a whole lot, but I did get to see a lot of deliveries. And I finally, near the end of my rotation, was able to deliver my first baby, and everything went well. And it was really, I didn't drop it or anything. And baby seemed fine, and mama seemed fine, and I seemed happy. And, honestly, with all the trials and tribulations in medicine, delivering a happy, healthy baby is like the funnest thing that there is to do. And then my next rotation was internal medicine, where I did 5 weeks at the Long Beach VA and then 5 weeks at UCI Medical Center. The Long Beach, of course, they were mostly veterans, and unfortunately, a lot of the veterans hadn't taken great care of themselves, and we saw a lot of illness due to alcohol and tobacco, and a lot of cancers and a lot of heart disease. I would have to say, though, that the veterans were almost every single one was fabulous. And I really, really enjoyed working with the veterans. And they taught me a lot, and they let us do things to them that was very brave of them. And it was just a fantastic experience. We had, I think at the time, our VA was the largest VA, and there was 4 call teams at night when we were on call, and we were one of the 4 teams, and our team would receive 20 to 25 admissions each night. And so those patients were in addition to our other patients that we already had. And it got overwhelming at times. I had over 20 patients myself at one time, and as a medical student, that's tough, but fortunately I had good residents and they helped out and we all got through it. And then I went to UCI for the next 5 weeks, and we had actually kind of a narrower spectrum at the time. There was a lot of HIV patients when I was there, in addition to oncology patients, but really a lot of HIV. And I spent a lot of time caring for these people, and it was a terrible time because not only was their illness devastating, there was a lot of social stigma to having HIV at the time, and religious leaders were denouncing these people, and it was very difficult. And the other thing that made it hard for me was my mentor. The medical center was an academic physician, and I guess he's published over 100 papers, and he didn't seem interested in teaching us, but only in criticizing us. And I found that very difficult. And I actually developed a term for that type of person, and I call them an academic anus, and which he was, and did not do me any good. But anyway, that was the end of internal medicine. And then I went to psychiatry, where we did 4 weeks of inpatient psychiatry. I was at the VA, and you know, a lot of young military people develop psychiatric issues. Schizophrenia comes on, there's depression, post-traumatic stress. We did a lot of clinics, a lot of group sessions, and took care of the inpatients. And my most difficult patient was a sailor who was raped by other sailors on a submarine. And in my time there, I saw no significant improvement in his mental health. He was very, very sick. Just a little funny story. A friend of mine, who I think is listening tonight, was on psychiatry at a different time than me. And there was only one phone in the main patient area for all the patients to share. And one of the patients' phone rang, and a patient answered it. And he said, "Who's calling?" And the patient said, "The President of the United States." And my friend said, "Yeah, sure, you know." And he went, took the phone, and sure enough, it was the President of the United States. He was calling to check on the husband of a woman who used to work for him. So it was, you just never know. And then the last
Which president
rotation.
was it?
I'm sorry?
Which president was it?
Ronald Reagan. So anyway, so the next rotation was primary care, and this actually occurred all throughout the third year. We were given a half hour each week, I'm sorry, a half day each week at the primary clinic of our choice. We could choose between family medicine, internal medicine, and pediatrics, and I was interested in family medicine, so I chose the Laguna Beach Community Clinic, where I went for a half day each week for the year. And I had a great mentor, and I worked with 3 other students, and the clinic was transitioning at the time, and we actually were working out of an old house right in downtown Laguna. And it was sort of like the Patch Adams experience, where, you know, the bedrooms were the exam rooms, and the living room was the waiting room, and the kitchen was the doctor's room. And it was great. And what I really liked was the continuity of care and getting to know people. And you know, sometimes you look at a schedule and you go, "Oh, gee, I wish they weren't coming in." But other times you look at the schedule, "Oh, I'm really excited to see this person or that person." You know, it was really great. And we saw really a wide variety of patients. There was a lot of homeless people in the Laguna Beach area because the weather's warm, and the beach has showers and restroom facilities that people can use. And so they often lived in the open spaces, you know, around the town. And of course, a lot of drug addiction and mental health issues, in addition to the regular issues that people have. My favorite patient was our 90-plus-year-old internationally famous artist. There's Laguna Beach is an artistic community, and she would come into the clinic once a month, and had been for years, to get her vitamin B12 shot, because she felt that it really did her a lot of good. And you know, we just couldn't argue, and we enjoyed seeing her. So that was our highlight every week. And that was kind of the end of the third year. And then we went in the fourth year. And my first class was neurology, which I did at Long Beach VA. We had a Greek mentor, and we did inpatient and outpatient neurology. Treated illnesses like headaches and strokes, both ischemic and hemorrhagic, and epilepsy. We had patients with ALS, and boy, that was a tough thing. And also Parkinson's disease, you know, end-stage Parkinson's. We learned to read CTs of the head, and evaluate EMGs and nerve conduction velocities. But unfortunately, with neurology, Stroke patients often can recover, but a lot of the other patients are just on a gradual decline and is trying at times. My next rotation was 2 weeks of doing anesthesiology. And we worked both in the operating room and in post-anesthesia recovery. In the operating room, we had to do pre-op visits with patients and make sure they're okay. And once they're in the operating room, we were the patient advocate. We had to make sure their padding was right and so they didn't develop ulcerations and their IVs were working. And then, of course, patients under general anesthesia had to be intubated. So we would, the anesthesiologist, of course, did most of the intubations and start arterial lines. In my second week, I asked my mentor if I could intubate a patient, and she was very hesitant and, of course, went on and on about the importance of their teeth. But I managed to get the patient intubated without difficulty, and I also started an art line, and I was very proud of myself. And then we went to the recovery room. Recovery from anesthesia is generally a very prolonged process of several hours, and is a very high-risk process time for people aspirating, and they're also confused and disoriented. And so a lot of time in the recovery room, but very interesting. And then next I did radiology. This was just a very brief course of 1 week duration, and we basically sat in a small room with our mentor and looked at hundreds and hundreds of x-rays. And we also looked at ultrasound, CTs, MRIs, and nuclear medicine. Our mentor was great. He could look at an x-ray and no history and tell you so much about the patient that it was unbelievable. And he also emphasized the importance of knowing what is a normal x-ray versus knowing what's abnormal. And I thought it was kind of funny at first, but it turns out he was absolutely right. And my next rotation was dermatology. This was an elective rotation that I chose. I figured I would be seeing a lot of skin rashes, and it was done in a private practice in Newport Beach. And of course, with California sun, there was lots and lots of skin cancers, basal cells and squamous cells, and occasional melanoma, in addition to eczema and psoriasis and rosacea and acne in the younger people, and using retin-A and the criteria for that. So it's a very, very interesting and worthwhile rotation. I was not allowed to do any surgery because, as it was private practice and I was a medical student, he would not be reimbursed for this. So I got to watch lots of suturing. And then my last rotation at UCI was, in California, was rheumatology, which I did at the VA. And I did this because I felt I knew very little about rheumatology. And so I likely would have patients with ongoing rheumatologic problems. And we had a very busy, surprisingly busy inpatient service, and very busy outpatient clinics. Saw tons of rheumatoid arthritis and lupus and scleroderma and all the other rheumatologic diseases. It was very trying for some of, we had a very young individual die from lupus, and it was just so frustrating not being able to do much. And that concluded my rotations in California. I then set up away electives. I knew that I wanted to be in family medicine, so I set up an elective at the Oregon Health and Sciences University in Portland, Oregon, and at the North Colorado Medical Center in Greeley, Colorado. My rotation at OHSU, they had a very good reputation for their family medicine training, and also being from Oregon, I went there to see. Also, their program director was Dr. Taylor, who wrote a very famous family medicine textbook, one of the top 2 that was used in the country at the time. And Dr. Taylor was great. He actually asked me to read a couple of his chapters from his new book. But in general, I wasn't as impressed with OHSU because they have residents in every specialty, and their family medicine residents didn't seem to get the experience that I was looking for. I wanted to be trained to be able to do everything anywhere, including practice overseas, and that didn't seem to be the case there, but I enjoyed my time there. At North Colorado Medical Center, they didn't have other residents there. And I was assigned to internal medicine with 2 residents. And we had a very busy service and saw a lot of emergency patients and different type of trauma than we saw in California. In California, it seemed like it was more knife and gun type trauma. And in Colorado, it was more farming accidents and machinery type accidents with degloving injuries. I got to operate with a hand surgeon, and anyway, it was very interesting, but I didn't meet a lot of the residents. My wife was accepted to graduate school in nearby Colorado State, and so I did list this as my top program, and I was not accepted, and I think because I did not have exposure to the other residents. And then the next thing we did was we set off on our 4-month trip around the Pacific Rim. I was able to get that much time because of the research that I did after the end of my first year. And I set up a rotation in Bangkok and at the University of Hawaii again. And so we first traveled to Tahiti and Bora Bora, which, you know, is unbelievably beautiful, but also exceedingly expensive. We then went to New Zealand and traveled around the North and South Island. And I put a lot more detail in the book about our adventures, but I can see I'm kind of running on time, so I'm going to kind of breeze through these a little bit. We went to the Alps on the Southern Island, and I love New Zealand. I could live there. We went to Australia, and we drove up the East Coast and went scuba diving on the Barrier Reef and spent several weeks there. We then went to Indonesia, and we were in Bali actually during match day when I found out that I matched in Ventura. We then went out to a very nice dinner and dancing show afterwards. And then we went to Singapore and then through Malaysia and stopped in an island in southern Thailand. And then I went to Bangkok to Mahidol University, where they have the Bangkok School of Tropical Medicine. And I spent 4 weeks working there, and it was great. They brought in patients really from all over the world, not just Southeast Asia, so we could see diseases from everywhere and people with diseases, not just reading about them. And we had a lot of children with malaria, and I got to know a lot of the children quite well. And I was exceptionally lucky that I was assigned a professor just to mentor me the whole time. And so not only during the classroom, but in her laboratory, and she taught me how to identify the various species of malaria under the microscope. And it was fabulous. And after my time at the hospital, Shar and I got to go up into the refugee villages in northern Thailand. And we sort of got a better understanding of why all these people are continuously infected. There are parasites in the air and the water and in the soil. And if you treat them, as soon as the treatment's done, they get reinfected. And unless you eradicate the vectors, they're going to keep getting infected. After we left Thailand, we headed back to California, and we stopped in Hong Kong, which is an incredibly vibrant city at the time. And shopping was unbelievable. It was just a mega city. We then went to Japan and landed in Tokyo and saw the Imperial Palace, and then went to the historic capital of Kyoto, where there are hundreds of shrines. And we went to Hiroshima, which was my second trip to Hiroshima. And they have a peace museum there that is dedicated to the events of August 6, 1945. And there's a museum, and there still were stains on the bridge where people had been eviscerated, and it was a humbling time. We then went to Hawaii, where I met up with both of my sisters and their family, and I had my 30th birthday, and I worked at Dr. Sadiki's lab at the University of Hawaii again. He was away on the mainland unfortunate at the time. And so I wrote a report of my adventures in Thailand and attached pictures as well. And then we flew back and we flew to California, and it was graduation time. And graduation day from medical school, honestly, was a mixed bag. I mean, it was great to graduate, but we knew we had internship and residency ahead, which was frightening. And also all these friends that we'd made over the years, we knew that most of them we would never see again. And you know, different people match in different places. And there was really very, very few people that I saw after that day. And that was medical school. Are there any questions?
Yeah, we have actually a bunch of questions, and Lucia is going to ask you all of them, question you.
Okay, I'm happy to do so.
Well, thank you first off for sharing all those details of your med school experience. And I'll just start off with a first question. Someone asked, what study technique worked best for you during your time in medical school?
What study habit? I found a friend to study with, two friends to study with. We motivated each other, particularly at first. And we also helped each other out because there were so many things, you know, terms you don't know. And if your study partner knows them, it just saves so much time. And I think I got a 3.7 GPA in medical school, which was better than I did in undergraduate. And I just was so interested. I think interest is a big thing. I don't know about the rest of you, but when I took organic chemistry, I had very little interest in it, and it was exceedingly hard to study. And I guess maybe other than pathology and maybe pharmacology, the classes were interesting. And that really makes it easier. But study buddies and knowing who to stay with. The other thing that I did, I was actually invited to live in a house with some other classmates, and I actually chose not to the first year because I kind of wanted to study. I'd taken a few years off and I was ready to study, and I studied really hard. And so I chose not to live with my friends, and I rented out a room in a private home. And I think that helped my motivation.
Now, the good thing is now medical school is pass fail, so they don't do grades. The grades are pass fail or honors, and so I guess that's
all medical schools.
Yeah, I think it's I think the last holdout was Hopkins that I know of, but I think all of them are pass fail for the first 2 years, and then third and fourth is pass fail honors. So
okay. And even the part 1 of the NBME exam is pass fail now as well.
Yeah,
correct?
the USMLE, yeah, the part 1 is, so now there's more weight put on part 2, which somebody said in a couple of years they're going to make that pass fail. And so,
you know, maybe that's good. When I was a college student, there was a UC Santa Cruz's pass fail. And, you know, it's nice to pass all of your classes. My personal opinion was having a graded system inspired me to study harder. I don't think I would have studied as hard as if it was pass fail. But I obviously am not the expert in this area and have no influence over the decisions that are made. This professor that I said had won this award, he said, we hardly admit anybody from UC Santa Cruz because they don't have grades. So, you know, I don't know. It is what it is.
Yeah, undergraduate, it's you still get grades. As a matter of fact, Santa Cruz doesn't do, they do grades now too. So
they do. Okay.
They do grades and the notation. They do that. I actually know somebody who's a advisor there. He's like in the advising office, and he said that they changed that a few years ago, but that they still and I asked them why they changed that. It says, well, because UC Santa Cruz went from a campus of 4,000 undergraduate to about 35,000, and there's just not enough time to for
Wow.
professors to write those very descriptive things.
Right.
And also what you stated, that the problem was a lot of people were not able to get into graduate school or getting jobs because they didn't have grades. And so that was, I think, another one. But
Something else that I've seen since I've been writing this book is that a lot of the colleges have pre-medical advisory committees, which didn't exist when I was, where they'll have a group that will be dedicated to working with the pre-medical students and writing their letters of recommendation. And I think that's just great.
yeah, I think that's still it's not all places, or not every school has it, but a lot of them do, and that's where like the huge disparities are, where some of the more private elite schools have better advising and more support versus smaller or larger ones and publicly funded have less. So it's not, that's not what it's something that's not all created equal. There's
Right,
a lot of
right,
disparities in that.
right.
Sorry.
Well, we'll move on to the next question, which is someone asked, do you recommend studying or reinforcing any particular subjects from undergrad before starting med school?
Not really. It sounds kind of funny, but in medical school, they teach you what they want to teach you. I guess, maybe if you've already taken a class, like I took a graduate level class in biochemistry, so I waived out of it. So I reviewed that somewhat, but I really found that genetics and biochemistry and organic, they're all great, but really not that applicable to medicine. I hate to say, seems like a big effort to get there. And I guess you need the building blocks, but I cannot remember the last time I used organic chemistry for any significant purpose. So sorry, guys.
And then someone else asked if you could elaborate on your experience in the pediatrics rotation, taking patients to the plaza of the hospital, and how it helped you during residency. I think maybe they're referring to how
Oh,
you.
sure. Yeah. So when I was on the inpatient pediatrics, we didn't have a huge volume of patients. And so we'd have morning rounds and get our morning work done, but we'd have a couple hours free from between noon and 2:00. And when we'd come back and kind of do pre-afternoon rounds and then afternoon rounds. So we had this kind of break in the middle of the day. And I saw a lot of my class colleagues, go to the library and do this and that. And I actually had this one patient that I really liked, and he had spina bifida and kept getting urinary system infections and being hospitalized. And so there was, some of the kids are so sick they can't be moved out of the ward, but some of them are just there because they need to get infusions, but they don't need to be there all the time. And so I'd take a group of these kids down to the plaza and just, I asked their parents' permission, and I had to get a signed consent that said it was okay and that I wouldn't take them, beyond that. And I was kind of nervous about it, but I thought it was great for the kids. And sitting in a drab, isolated hospital room day after day after day is very depressing. And I feel mental health plays a big role in recovery. And so if I could do something to help these kids mentally, that was my goal. So we went down and worked like every lunch hour while I was there in the plaza, and then we'd take them back up. And the reason it helped me was because my mentor in pediatrics really thought it was great. And a lot of these kids' parents went to him and said how great I was. And so he wrote me a really strong letter of recommendation. And it was one of the 3 that I used to get into medical school. I had 6 or 7 written. And by the way, guys, it's not really a big deal to ask for a letter of recommendation. These teachers expect it. And if you've done well with them, I think they might actually be kind of disappointed if you didn't ask them. So there's no reason to be shy about asking it. And the same goes, when you're an undergraduate. If you want to do research, I just went up to my physiology professor and I just asked him, said, can I do research in your lab? And he actually was really thrilled to have me until I actually started working. No, anyway, but just don't be shy. I actually was a very, very shy person before medical school. And I said, this just is not going to work to be a doctor. You can't be shy and you just have to come out of your shell. And it's really better for everybody. So that's how it helped my career.
Thank you. And another attendee asked if you could speak to how you prepared for the USMLE tests and board exam.
I don't think that I am likely the person to ask good advice on that one. We were given a 3-week break for the part 1 of the exam. And I went to the Cayman Islands and went scuba diving. And the only thing I reviewed was my biochemistry. And the reason I did that was I studied really, really hard the first 2 years. And all of my classmates were stressing out. And I thought, well, that's a pretty good time to get a break before, clinicals. And so I didn't really study that hard. And for part 2, I didn't study at all. And part 3, I did not study at all. And I did great. So the secret is study all along, learn as much as you can. And if you want to study away, power to you. My classmates were flabbergasted that I didn't study. But I did great on the exam. So that's ultimately it counts. So sorry, I'm giving you poor advice, I know.
So the only thing I have to add to that is like to worry about the USMLE now is like worrying about I don't know, the alien invasion. I would say medical schools actually have like a vested interest, like financially, everything's for you to pass the USMLE. They have these like offices with, they're called like teaching centers or teaching and learning, that pretty much like they will sit there with you if you're struggling with classes. They have all of these like systematic things to help you with the board. So like, I wouldn't say don't worry about it.
That's my opinion too. Honestly, if you want to be a good doctor, you study while you're in medical school. If you study while you're in medical school, you do not need to worry about the tests. That's all there is to it.
Okay, the next question, someone asked if the gastroenterology rotation was an elective like dermatology. I'm not sure if that's...
I didn't actually do a gastroenterology. I did neurology, anesthesia, radiology, dermatology, and rheumatology. But yes, gastroenterology would be an elective. At our medical school, all of the classes, the first 3 years were assigned. But at the 4th year, you got a lot of leeway to choose your specialty and do electives. And I would say, 3/4 of the 4th year was electives that you could choose. So if you're interested in gastroenterology, absolutely set up a gastroenterology elective. And I was kind of lucky, I guess, when I was a researcher at UCSF, my boss was a gastroenterologist and he let me follow him in and see how colonoscopies are done. And in my family medicine practice, I actually did flexible sigmoidoscopies for several years. And the thought at the time was that's the way to go for low risk, but I finally convinced myself that I was still going to miss a significant portion of tumors that people have by only seeing half the colon. And so I stopped doing them and started referring my patients for colonoscopies.
Yeah, the only other thing that I would add is when you're in medical school, if you want to do an elective or even shadowing, it's a lot easier than when you're a pre-med student, because you're like in medical school. You've got there's people that want to, let you come into their club, so they're definitely more receptive, and some of the people, is their job to actually recruit you into their specialty. So if you want to do anything, I have like a friend of mine who's a 4th year medical student, and she wanted to do a elective in child abuse, and so she like is now like working with the county person who's in charge of the entire San Diego County, that does all of those exams, and like they've become really good friends, and so you don't have to worry about that. That's kind of the nice thing when once you're in medical school. Anything you want to do, the world is your oyster.
I fully agree. And of course, most of the people in the medical schools are on staff in the medical school. So if a medical student asks to work with them and they're denied, and that student then goes and tells administration, I think it's a problem. So really, you're absolutely correct.
Okay, and we're getting a couple questions asking on any advice you have on how to increase your chances for matching into a residency program that you want.
I think doing a rotation at that site and getting to know some people would be a good way to do it. That strategy, however, can backfire. At the residency I went to was a very competitive residency. And during my residency years, we did have some students come in who turned out to not be outstanding students. So it kind of backfired. But if you are a good student and you're realistic about where you're applying, then setting up an elective at that facility, I think would be a great idea.
And then someone asked more of a clarification question of, or if you could describe what an attending is as your.
Yeah, absolutely. The attending physicians are the staff physicians who oversee the residents and the medical students. And like at the VA hospital, they're typically employed by the VA, and at UCI, they're employed by UCI. And so they're the ones who are ultimately responsible for all the patient care. And even though they usually do virtually no patient care other than attending rounds. So they're the bots and they make the decisions. So like on our morning rounds in internal medicine, we would get there at 4 a.m. and see all of our patients and do all of our blood draws. And we were responsible for starting all of the IVs that failed and putting in Foleys that people pull out at nighttime. And so we'd see all of our patients and write all of our notes, and then the attending would show up. And we would walk around in the hallways and discuss each patient outside of their room. Whoever had that patient, whether it's a medical student or the resident, would present that patient to the attending physician. And he would ask questions, and then we would go into the room and he would meet the patient and discuss what we had told him and see if, and invariably, their story always changed from the time they told us the story that morning till the attending came, but it was a persistent problem. But so that's what the attending is. They're the ones who are responsible for the patient's care and overseeing the residents and medical students.
So the only question or clarification, so an attending is someone who like how does one become an attending also, like
by becoming on the faculty of the medical school or of the VA. So like say you're internist and you do your residency and then you do a fellowship and then you want to be an attending, you want to work at a medical school, you want to be a researcher. So then you apply to wherever you think you can get a job, and say you get hired at UCI. So then you become an attending physician in your department. You have to see patients generally in clinics. Like if you're a gastroenterologist, you go to the GI clinic. But then if you also have GI residents, then you become an attending for those residents, where you oversee their activities and make sure the care that they're giving to the patients is appropriate. Does that make sense?
Yeah. They're basically the chief, the buck stops with them type of thing. So yeah, but because I think
El Jefe, the chief, that's right. They're the ones who are in charge and ultimately responsible. So say this third-year medical student's caring for this patient and I make a mistake and the attending doesn't catch it and a bad outcome happens, the attending is for sure named on the lawsuit. So they want to take care of their patients.
And the other thing is, and the attending's name's on the chart too. So
yes, yep, that's right. And as a medical student, your notes all have to be co-signed by at least a resident and sometimes by an attending. And your orders, until you're a licensed physician, they all have to be co-signed by a licensed physician. And you typically get your license end of your internship year, when you're then and pass your third part of the boards, and then are eligible to be licensed.
Okay, we have one last question, which is if you could speak more to how you, while you were in med school, how you decided to pursue family medicine afterwards.
Here, good question. First of all, family medicine and pediatrics are the lowest paying specialty. I knew this. I did well in medical school. I could have made a lot more money. What I wanted to do was I wanted to learn as much as I could about everything. I wanted to learn how to deliver babies. I want to learn how to take care of kids. I want to learn to do surgery. I wanted to practice overseas down the road. And I wanted to be able to practice in the country. I saw a family doctor growing up. And like I said, I spent a lot of time around doctors and hospitals. And, you know, for me, it worked. As I mentioned, in my third year, I spent a half day a week at the family medicine clinic in Laguna Beach. And I just love the continuity. I mean, I really did. And there's I've practiced a lot of emergency medicine in my career and urgent care as well. And, you know, there's some advantages in just doing your work and going home and not being on call. But I delivered babies after I came out. I did ICU medicine. I did C-sections. I ventilator management, floated swans. I mean, I just did everything. And I really liked it. And that's what I wanted to do. I think a lot of people have a idea what they want to do before they start medical school. I know not everybody does. That's where your rotations come in. You know, if you spend 10 weeks on internal medicine and you like it, well, maybe you want to be an internist. If you spend time on peds and you like it, maybe you want to be a pediatrician. You know, I like those rotations. I just liked family medicine more. And that's what I wanted to do.
My question also is, so since family medicine is the lowest paying specialty, did you ever starve or not be able to pay your bills or own a house, or not be able to find a job?
I went to a really good residency, and I was always able to find a job, no problem. Literally, I could have worked lots and lots and lots of places. The first place that I chose to work was in Central Oregon, and it was a private clinic of 7 other family doctors. And I chose to work there because I like that part of the world, and my father was still alive, and I wanted to be closer to him. Unfortunately, the clinic practice was terrible. I was guaranteed $42,000 a year, and that's what I was paid by the clinic. We had an arrangement where we ran the hospital ER at nighttime, and I think I was paid $90 an hour at the time. And I did 2 12-hour shifts a week. And with that, my income made it up to about $90,000. Now, this is a few years ago, but it was a terrible financial situation, just terrible. And I also worked like a dog. I was delivering babies, and so I was on call every night, and I was in the ER all night, every third night, and I was on backup call all these other nights. And, you know, I struggled, and after 3 years, I left that practice. And then I moved to Salt Lake City into more of a clinic-based family medicine. And I did take call at 3 hospitals, but our income was better. Unfortunately, we had a great deal of pressure to partner with somebody because we were private, and most of the physicians were associated with Intermountain Healthcare, which used to be part of the LDS Church, but was spun off, but really dominated the market. And it really was just us and the University of Utah and IHC were the three major providers in the area. So we teamed up with somebody else, and unfortunately that didn't work out, and they sort of backed out, and we got into financial problems. And so I moved on, and then I moved to Minnesota. And when I moved to Minnesota, I went in to do urgent care. And this time I lucked out. This was a very successful practice. And we also had revenue sites. We owned an oncology center. We owned a pharmacy. We owned physical therapy. We owned a heart institute, co-owned a heart institute. So we had these income centers that helped bolster our income. And I worked, when I was in urgent care, I worked 45 hours over 7 days, and then I had the next 7 days off. And then I had 3 of my work weeks off. So I worked 23 weeks a year, and I made close to $250,000. And so a lot of it just depends on your practice. And really, you know, at our first clinic, we were so busy, we couldn't believe it. And people say, how can you be that busy and not make money? And the answer is, if your bills are more than you bring in, then you don't make money, you know. And these days, a lot more doctors, in fact, most are joining health organizations where the income is a lot more guaranteed and a lot more fixed and kind of less dependent on your production.
My other question is, you had this ability to move across the country, and so how easy was that, or how were you able to do that? And so moving across the country.
Oh, it's very easy. I did not have to really do anything special other than be licensed in the new state. And typically when I moved to these other clinics, they had administrative staff who would send my medical school transcripts and residency transcripts and DEA number and all this. And I never had any trouble being licensed in any of the states that I choose to attend. It was easy. But that's also why I went into family medicine, because I wanted to be able to travel and have opportunities and work in a small rural town and work in a city and work in emergency medicine and work in urgent care and deliver babies or not deliver babies. I just liked the variety of options that were presented to me. And as far as there being a shortage of jobs, I don't think so. At least what I've read is there's going to be plenty of opportunities for physicians for quite a while to come.
Excellent. Anybody else has any other questions? If not, we're going to let our speaker go.
Well, I would like to thank you very much for the opportunity to present today. And I'm going to ask Jobin for the email addresses for the people who attended, so I can send you a letter of thank you for attending tonight. And I really appreciate it very much. Thank you very much.
Thank you again. Yep. Does anybody have any questions? No, thank you. Just see if any of them were posted. All right. Anyone? Nope. Oh, I have one. Okay. The anonymous persons that they have a question, please type it and then we'll. Lucia had to go to work, so.
Oh no, that's fine. That's fine. I kind of rambled on. I'm sorry if I.
No, that's okay. No, she just had to. She just starts work at 7, so she had to.
Yeah.
Scooch on out. Um, what are your thoughts on physician shortage, and what do you think the short term and the long term solution would be?
Um, well, I mean, I think it's pretty clear that there is a physician shortage. Um, since my days of starting medicine, I know that nurse practitioners and physicians' assistants are becoming more and more widely used. And in fact, a lot of these hospital companies like to use as many of them as they can because they don't have to pay the salary that they pay physicians, although in some cases it's not greatly different. You know, there's more medical schools, there's private medical schools now that are somewhat addressing that issue, but I just can't see that it's really going to change right away. In fact, I think it's going to get worse before it gets better, which if you're applying to medical school, I guess is good news. If, you know, if you get in, kind of a downside to the physician, and I experienced this when I worked in urgent care, is that I was responsible for supervising two PAs in addition to seeing patients myself. And I worked a 7-hour shift, and sometimes in that 7-hour shift, I would see 60 patients myself and supervise another 50 to 60 patients with the PAs. And so that really puts a stress on you, you know. Admittedly, a lot of these are ear infections and sore throats, but we also did a lot of lacerations, and because we were the only urgent care, we had a lot of chest pains and abdominal pains, and patients that would take a fair amount of time. I did orthopedics initially, but after I went to urgent care, the orthopedics surgeons in town didn't care too much for an urgent care doctor, you know, doing full treatment of a fracture, and so I ended up just splinting the people and then referring them to the orthopedic surgery for follow-up. But I don't know. I guess the future looks bright for physicians. I hope it looks as bright for our patients. Anything to add, Shobin?
No, I just personally think that Congress needs to increase Medicare funding for residency spots, but
Yes.
that's
Yeah.
that's something that neither you and I have the power than to just vote.
No, interesting. When I graduated medical school, there was more spots than there were graduates. And I think the opposite is true now.
Right.
And all I have to say is if you get into a decent medical school and you do decently, I think there's bigger things to worry about.
Yeah, there's been a couple of questions that have been asked about people not matching into residency, and I think that's been like, and it's been covered in the news. And I think the bottom line is that there is still enough residency spot, but you know, like dermatology is very limited. Or, you know, there's certain specialties that have really good lifestyles, and so
Right.
everybody wants to do that. Good lifestyles and good return.
Right.
And so those are just,
That's right.
you know, those are really the challenge has been that, you know, but there's a lot of spots that, like I know the hospital that I work in, the family medicine residency didn't get enough applicants, that they had to get people through the scramble, which but they were able to fill it, and everybody had a job and everybody was great. So
Right.
but yeah, and so that's kind of been the challenge. Somebody asked, practicing family medicine during the pandemic, um, how was practicing family medicine during the pandemic?
I didn't. I'm
Okay.
retired.
Okay. Yeah, I work in the ER, and it's definitely been changed. We had to go from seeing patients to putting on garbage bags, and at the beginning of the pandemic. So it's been challenging, but I think you go into medicine and healthcare because you want to help people, and you just have to deal with whatever's thrown at you and do the
Doesn't
best
seem
that
you
you
really
can.
have a lot of choice, you know, it's
Right.
just what you have to do. you do what you have to do.
Yeah, you just have to be resilient and
Yeah.
put one foot before the other and just do it. So
That's exactly right. And,
how long have you?
I mean, like when I was training, there was HIV, and if you stick yourself, you die. And now there's the pandemic, and, illness is an occupational hazard of physicians. It just is.
Yeah, definitely. Well, I want to thank you. I actually have to go to work myself, so
Well,
I'm
thank
gonna
you.
thank you again.
That was fabulous. Thank you very much.
Thank you very much, and nice meeting you.
Nice to meet you.
Uh,
And if you have any
um,
questions, don't hesitate to contact me.
yeah, absolutely, and I will email you that thing too as well. And thank you for